All right, good morning, everyone. I'm just going to wait for a few more people to join. Okay, good morning. Thanks for joining us this morning for a webinar that will explore state data approaches to neonatal abstinence syndrome. A few logistics before we get started. Everyone's lines will be muted during the webinar. To ask a question or make a comment, please use the Q&A function. The chat will also be available. And there will be an evaluation at the end of the webinar that will pop up in your browser. So please fill that out. It really helps us and will help us create more programming for you. And thanks. I'm going to kick it over to Kitty. Kitty, I think you're muted. Sorry.
Sorry about that. Welcome everyone to today's webinar on state data approaches to neonatal abstinence syndrome. And we are really pleased to have a great slate of speakers today. My name is Kitty Purington. I'm from the National Academy for State Health Policy. And for those of you who are not familiar with NASHP, we are a nonpartisan, nonprofit organization. We were founded over 30 years ago by and for state health policymakers to convene state policymakers and assist them in improving policies and practices across their states. And we do that by working with states across the country, with various agencies and across branches of government. So today we're going to be hearing about some state innovations and best practices around collecting neonatal abstinence syndrome data. As we know, this data can live across multiple agencies. It can have different formats, be driven by different definitions. And all of this really complicates and creates challenges for state policymakers interested in understanding critical NAS trends and prevalence data within their states, and importantly, creating policies that can help families get the supports that they need. So today we're going to be hearing from two states, Pennsylvania and Kentucky, who are going to be walking through the efforts that they have made and the innovations that they have done in their states to gather this data and to really look at the data and think about how they can improve policies and outcomes in their states. Before we get to those presentations, I would love to introduce Dr. Karen Scott from the FOR Foundation. NASHP is incredibly grateful to the support that it receives from the FOR Foundation. So I'd love to turn it over to Dr. Scott to talk a little bit about the work that they are doing, all the great work that the foundation is doing in its efforts to address the opioid epidemic.
Kitty, thank you so much. And FOR is really thrilled to be a partner with NASHP in learning from states, as well as helping to disseminate best practices and continually improve our ability to address the opioid, the substance use crises around the country. You can go to the next slide. As Kitty said, I lead the Foundation for Opioid Response Efforts, which is a fairly new foundation launched late in 2018 as a private, primarily grant-making foundation focused on the opioid crisis. Our vision is to inspire and accelerate action to end the opioid crisis. And all of our work is very much based around solutions and around funding grants and projects that can help drive learning and inform long-term solutions. We focus on work that is very patient-centered, and our projects, the projects that we fund include a focus on professional education, supporting payer and provider strategies, work on policy initiatives, as well as providing information and increasing public awareness. We've really developed over the past 2 years, we can go to the next slide, a three-part three complementary activities for our work. Core to the work is as a foundation is our grant making, and our strategy has evolved and is continuing to evolve. But we have a real focus at the center of it in equity and a focus on the most vulnerable populations in our society. Our grant programs so far have focused on improving access to treatment for OUD, and a number of grants have focused on responding to COVID, particularly supporting recovery services around the country, and a number of policy research projects to make sure we're learning from, as you know, some of the temporary changes in access to treatment that have been in place during the pandemic. We're right now working on both a program around innovation as well as have an open RFP on prevention and with a focus on vulnerable families. So our grant making strategy continues to evolve and develop, and always happy to talk with people more, not only about our grants specifically, but about how we are developing that strategy. In addition to the grants, we have also developed a number of convenings, bringing together our grantees as well as other experts, and related to that, developing a number of issue briefs and other resources for the field. All of that is on our website, and I encourage you to go to our website and really see both all of our grantees as well as tap into some of these resources. And we can go to the next slide. Specifically with respect to today's topic, if we click on the slide again, say, okay, I could click again and just get the whole, yep. Thank you. Specifically with respect to today's topics, we do have a number of grants that we're funding that focus on pregnant and parenting women and children. We have done convening, focus both as part of our access to treatment and convening of advisors on family and community-based prevention that certainly have young families, infants and children and their parents as a focus of that work. In terms of our grants, we have grants currently with the University of North Carolina Horizons program, which is a residential program for pregnant and parenting moms and their infants and children, a Renewal House recovery program, also a residential program that's based in Nashville, and a program with the University of North Dakota, which is developing a number of resources and tools for women postpartum to be able to support the mom being able to stay in treatment, as well as strengthen parenting skills and the supports that the infant needs as well. And then finally, again, on our website, you'll find a number of our resources that focus on families and pregnant and parenting women, number of issue briefs that go into some detail about what we're learning from these initial grants, as well as the related policy issues. So again, I'm very much looking forward to today's conversation to help add to what we're learning from our grants, and to help us and to continue to think about where the opportunities might be for the foundation to help in moving this work forward. Critical work in terms of making sure we're learning and implementing policies and practices that can strengthen the health outcomes for both parent and infant. Thank you, Kitty and NASHP team. And I'll turn to listening mode.
Great. Thank you so much, Karen. We really appreciate it. And so I'm actually going to turn it over to my colleague, Eliza Mehta, who's going to be talking, give us an overview prior to the state presentation. So Eliza.
Thank you, Kitty, and good morning, everyone. My name is Eliza Mehta, and I'm a policy associate here at NASHP, and I'm going to give a very brief overview of state processes for collecting, reporting, and sharing NAS data, so we can get to the actual state presentations. Next slide, please, Mia. As I'm sure many of you are aware, there has been a pretty significant recent increase in NAS incidents. In the past couple of years, several states have seen a slight downtick, but it is still significantly prevalent syndrome in the US, and certainly in part driven by the opioid crisis. We've seen that rates of NAS are disproportionately high in babies born to parents who are covered by Medicaid or uninsured. And this in turn means that Medicaid and state Medicaid budgets end up bearing a disproportionate cost of NAS treatment and care. And so it's important that states have an understanding of what their NAS data looks like, how to share it, and how to leverage it to inform better policy. Next slide, please. There are two major federal laws that govern NAS reporting and data collection. CAPTA, which was subsequently amended by CARA, basically require that states have a process in place to report basically NAS case identification to Child Protective Services with the intent of developing a plan of safe care that both addresses the health needs of the infant and, importantly, the caregiver or parent. However, CAPTA and CARA do not standardize the definition or data collection processes when it comes to NAS. And so states are left to develop their own case definitions and reporting processes, which means that there's quite a bit of variation across states. Next slide, please. We see quite a bit of variation when it comes to reporting strategies. So mandated reporters range from individual providers and healthcare facilities, including hospitals and birthing centers. Reporting methods range from comprehensive forms and more passive hospital registries. And timing of reporting can be mandated within a couple of days of diagnosis, within 30 days, or as part of a more regular chart review. Next slide, please. And we see that NAS data are generally reported to two different major agencies. We have the Child Protective Services agency within the state, and that is for purposes of the CARA CAPTA requirements. But there's also a reporting process to state departments of public health, and that is for public health surveillance purposes that seeks to address not only infants born with NAS and their care needs, but also addressing maternal opioid use disorder and drug-associated maternal mortality. Another important data component to consider is Medicaid claims data. And as Medicaid bears such an important and significant treatment and cost burden when it comes to NAS, this is a really rich source of data for states as well. Next slide, please. So one last slide here on background information. Frequently and in most cases, a report of NAS to Child Protective Services is not a de facto finding of child abuse. And while best practice is to treat pregnant people with OUD with medication for opioid use disorder, pregnant people might be hesitant to engage with healthcare systems, both for prenatal care and for postnatal care, due to fear of repercussions from Child Protective Services, the involvement of Child Protective Services, and other criminal legal repercussions. Despite these siloed data systems, states are making pretty phenomenal efforts to link and share these data, including the states we have today with us, Pennsylvania and Kentucky. They were instrumental in helping us prepare a report linked below about state approaches to leveraging these data. And so without further ado, I would like to turn to Pennsylvania. We have Karen Decker and Chelsea Hammond with us here today. Chelsea is a nursing services consultant with the Pennsylvania Division of Newborn Screening, and Karen is an epidemiology research assistant also with the Pennsylvania Division of Community Epidemiology. Thank you both for being here today, and I will turn it over to you.
Thank you, Eliza, for that introduction, and thanks to NASHP for the opportunity to be here this morning. Hi, everyone. My name is Karen Decker, as Eliza mentioned, and I'm here today with my colleague, Chelsea Hammond, and we're excited to share some information about Pennsylvania's Neonatal Abstinence Syndrome Surveillance Program. If you could advance to the next slide, please. So before we really dive into providing an overview of the data collection process in Pennsylvania, we wanted to share a little bit about the NAS surveillance process and authority and how it really got started in Pennsylvania. So the impetus for NAS case reporting in PA was a 90-day state emergency declaration that was declared by the governor for the opioid epidemic in January of 2018. So as part of that disaster declaration, the governor made NAS a reportable condition, and that's what required rapid case ascertainment for us. So within a month of that declaration, Pennsylvania's Department of Health, specifically the Bureau of Epidemiology, developed a web-based reporting system and provided birthing facilities and hospitals with guidance on how to submit and report NAS cases to us electronically. At the time in 2018, there was no national standardized NAS definition, and it also wasn't defined in Pennsylvania's statute. So we developed our own case definition for use in 2018 and 2019. And in the following slide, I'm going to share a little bit about how that definition has evolved. In 2020, NAS surveillance in PA went through a bit of a transition. So the Bureau of Family Health's Division of Newborn Screening and Genetics actually took over some of the NAS case reporting in PA, and our definition was updated to be in alignment with the Council for State and Territorial Epidemiologists' standardized NAS case definition and position statement that was published in 2019. So I do want to note that the statewide opioid disaster declaration, which, as I mentioned, was really the impetus for our reporting process in PA, was renewed 15 times before expiring in August of just this past month. However, NAS reporting remains in effect under existing Department of Health authority. And in the subsequent slides, we're going to share a little bit more on what this looks like in practice and how the data are collected and utilized by the Department of Health and its partners. Next slide, please. Thank you. So effective January 2020, Pennsylvania started using this case definition, which you can see here on the slide, which again, as I mentioned, is in alignment with the CSTE case definition for Tier 1 reporting, if you're familiar with that position statement. And we require reporting for both confirmed and probable cases. So prior to 2020, we were looking primarily, solely really at infants with known exposure to opioids alone. But in 2020, we expanded that definition, as you can see here, to include exposure to benzodiazepines or barbiturates. And that exposure, taking place due to known use of drugs via prescription, medical therapy, or illegal use. If you could click again on that slide, please. Thank you. So hospitals and birthing facilities in PA should report all NAS cases in babies up to 28 days after birth that are showing symptoms of withdrawal. Again, as I mentioned, due to those exposures. And then these are the criteria that we provide to our reporting facilities. So for confirmed cases, the criteria dictate that there must be a positive infant drug screen and at least one of the 3 items listed. So newborn diagnosis of NAS, chief complaint, or 3 or more clinically compatible symptoms. And then for probable cases, again, it's evidence of maternal history of drug use, and then one of the 3 items listed below. So in the next few slides, Chelsea is going to provide additional detail on our case report form and also how this works in practice.
Okay, thank you, Karen, and thank you so much for that introduction. In the state of Pennsylvania, all NAS case notifications are submitted through the Internet Case Management System, or ICMS. This is a web-based software application developed and supported by Neometrics, and this is a division of Natus. ICMS is utilized by the Pennsylvania Department of Health's Division of Newborn Screening and Genetics and provides the state with a single comprehensive data system. In addition to NAS reporting and surveillance, ICMS is utilized to track and manage newborn screenings and point of care testing. So this would be things like congenital heart defect and hearing screenings. Next slide, please. And as Karen mentioned previously, hospitals and birthing facilities are advised to report all confirmed and probable NAS cases to the Department of Health per CSTE's definition for NAS, and cases aligning with the definition for suspected do not have to be reported. All NAS case notifications are to be reported to the Pennsylvania Department of Health within 4 days of discharge or 28 days of life, whichever one comes sooner. And hospitals should not report non-Pennsylvania resident cases. All NAS case notifications entered into ICMS are reviewed by the Division of Newborn Screening and Genetics to verify that reporting requirements are being met. Next slide, please. So now we'll take a look at our reporting form for NAS. This is the first section on the reporting form, and that's patient information. It includes the reporting date, reporting facility, medical record number, initial filter paper number from the infant's dry blood spot test, the infant's first and last name, infant's date of birth, gender, birth order, APGAR scores, mother's information, and then the principal source of payment. Next slide, please. The neonate assessment scoring includes Finnegan and modified Finnegan scoring, as well as an option for other. So hospitals can select this option if another assessment tool such as Eat, Sleep, and Console was utilized. Next slide, please. Infant status includes medications or therapies used to treat the infant, or the option to choose no treatment if it applies. And the infant signs and symptoms of withdrawal are also located in this section. Next slide, please. Neonatal lab testing is noted here with the ability to list the source of the lab sample. Specific drugs which the infant tested positive for should be noted in this section as well. Next slide. Infant discharge plan includes any referrals that were made for the baby. So examples of this would include childline and early intervention. A plan of safe care initiation is also noted in this section, and submitters are required to enter a discharge date and discharge location, such as discharge to the parents, CYS, or another location. Next slide, please. This is for PCP information, pretty straightforward. Next slide, please. Mother's discharge plan includes potential variables such as continued MAT, home visitation services, and behavioral health services. Next slide, please. And the next section accounts for antenatal maternal drug use and 4 weeks prior to delivery and whether or not the mother was receiving MAT. The reporters have the ability to include multiple substances when submitting an NAS case notification. So next, Karen will talk more about data transmission and storage.
Thanks, Chelsea. So this slide provides a little bit of a recap of the process that I described, and also of the case report form that Chelsea just walked us through. It provides a little more insight as well on how the data are transmitted and stored. So all hospitals and birthing facilities in Pennsylvania that are reporting are required to configure their systems and complete training prior to electronic submission of data of the case reports via the internet case management system. And again, that case report form that Chelsea walked us through. So kind of walking through this flow, upon identification of an infant that meets the NAS reporting criteria, hospital staff responsible for reporting log into the ICMS secure server and enter that data in the case report form. Neometrics, which is a division of Natus, owns the application and hosts and maintains ICMS, which is that case management system, as well as houses the the data on an offsite server. So data entered in ICMS is then available to the Department of Health staff the next calendar day, and reports can be generated directly in ICMS as well as, exported for additional analysis for follow-up, estimating incidence of NAS and to assess trends. Next slide, please. So just to wrap up, these are some of our goals of NAS surveillance. I would say that we really aspire to achieve all of the NAS surveillance goals that are described in the Council for State and Territorial Epidemiologists position statement. Goals include estimating incidence, but also, ensuring that we're allocating resources appropriately to affected families, connecting families with services. And if you go to the next slide, and these are some additional goals that really kind of further emphasize, some of what we're hoping to do with the NAS surveillance data received, including ensuring that we're connecting families and infants to services, improving referrals, and ultimately, keeping our opioid command center and department advised as we continue to coordinate the opioid response. And next slide, please. All right, thank you so much. And now I think I'm going to turn it back over to Eliza, who will continue our webinar.
Thank you so much. That was wonderful, a wonderful presentation. And thank you for going through all the different components of your reporting forms and processes. I think that's very helpful for states. Quickly, before I turn it over to Kentucky, I will just say I'm seeing questions popping up in the Q&A and in the chat. We are going to have a Q&A section at the end of the webinar, so I will get to those as soon as we're done with the facilitated discussion. So thank you for your patience. All right, now I'd like to turn it over to our speakers from Kentucky. We have Tracy Jewell and Dr. Henrietta Botta with us today. Tracy is an epidemiologist 3, manager program support with the Kentucky Division of Maternal and Child Health. And Dr. Botta is a director of the Kentucky Division of Maternal and Child Health. And thank you both for being here today, and I will turn it over to you.
Okay. Thank you very much for the invitation, and we are pleased to share with you our experience with the Neonatal Abstinence Syndrome Registry in Kentucky. Next slide, please. You can see from this map where Kentucky is, where that red hot zone is, and that's where we are. And we are, I think, number 5 when it comes to the deaths from the opioid epidemic and death from overdose. And of course, as mentioned earlier, the increase in NAS cases, and of course, the associated increase in hospital costs. Next slide, please. So because of the opioid epidemic in 2013, Kentucky General Assembly enacted the KRS 211.676 that all cases of neonatal abstinence syndrome diagnosed among Kentucky resident births shall be reported to the Kentucky Department for Public Health by the facility where NAS is diagnosed. And the report shall be made at the time of NAS diagnosis pursuant to guidance issued by the department. And then part of the statute, there's also a call for an annual report of the identified aggregate statistical data from this reporting. So annually, we have to give a report. It was in 2014 that actually the legislation went into effect. Next slide, please. So here's our rate of NAS among Kentucky resident newborns. From 2001, with practically very few cases. And then in 2019 and 20, we're at 20.9 per 1,000 live births. So in 2015, we had as many as like 1,500 newborn babies reported to have NAS. Next slide, please. The nice thing about the surveillance registry is that we are able to at least look at different area development districts in Kentucky. And you notice that at least in the southeastern part of Kentucky, we have the highest incidence, as high as 56.7 per 1,000 live births in some areas. Next slide, please. The other thing that's interesting is that when we overlay the map, geographic location or incidence of NAS by districts, and we look at our sudden unexpected infant death, they practically, you find the high number of sudden unexpected infant deaths in areas where we have also a high rate of neonatal abstinence syndrome, which made us look further into the way we're doing or we're implementing our plan of safe care. So this is just an introduction, and Tracy will give you what the details of the surveillance reporting. Tracy.
Thank you. As Dr. Botta mentioned, our NAS surveillance registry was enacted and put into effect in 2014, midway through the year. So our data in our registry actually covers calendar year 2015 forward. Those first few months of 2014, there just were not a lot of reporting. So we started off, we had a reportable disease form that was submitted to us by the hospital where the infant was diagnosed with NAS, and they were required to utilize ICD-9 code reporting, which we subsequently crosswalked with ICD-10 codes. And in Kentucky, we developed our own case definition, and guidance was not offered by the particular statute. So we include any infants with signs and symptoms consistent with NAS or known exposure during pregnancy. And these babies are included regardless if they were treated with medication or not, and regardless if they had a score, a Finnegan score or not. We also collect drugs other than just opioids. We include any exposure from several different classes of drugs, which I will show you later on. In the beginning, we had a fax form that was completed and sent to us through a secure fax line, which we then subsequently changed over to a secure web-based reporting system, and all of our data is housed in REDCap. Also, it is stressed to the reporting facilities that our registry does not fulfill the requirement to make a report to Child Protective Services. Next slide, please. So this is just a very brief overview of the major categories contained within our NAS reporting registry. We begin with demographic information on behalf of the mom and the infant, and we collect very specific identifiers on both. And this information is utilized later in linkage to other data systems. We also require several demographic factors from both the birthing facility and the reporting facility. And the way our law is, if an infant is born at one facility and transferred to another facility, both are required to report the NAS diagnosis to us. And then those two reports are later combined and a deduplication process takes place before analysis of the data. As I mentioned, several substances are collected at the time the report is made. We do collect a self-report maternal history from the mom, but we also have information on what both the mother tested positive for and what the infant tested positive for. And these include several classes of drugs such as heroin, cocaine, amphetamines, methamphetamines, as well as opioids, benzos, SSRIs, and others. We also have a complete section on signs and symptoms the infant experienced, or if they were asymptomatic, there's a checkbox for that as well. The signs and symptoms are grouped into three major categories, covering what could be experienced through gastrointestinal symptoms, neurological symptoms, and autonomic symptoms. We also collect if the mom was on MAT therapy, breastfeeding status, and if the CPS referral was made, if it was accepted for investigation or not. We also have a whole section on the treatment of the infant. If pharmacological treatment was enacted, we collect the type of medication and the date and time administered. We also do collect length of stay information, and the discharge disposition indicates if the infant was discharged home with foster care parents, mom only, mom and dad together, if it was adopted, that type of information. Next slide, please. So all of this information is utilized for several things. As Dr. Mata mentioned, the second half of our reporting law requires us to develop an annual report that goes back to the General Assembly as well as stakeholders and the birthing hospitals. This report is located and published on our website annually, and it includes the sections that you see listed here, as well as a whole section on recommendations for prevention based off of the data collected. Next slide, please. We also utilize the information to give back to the birthing hospitals and reporting facilities. We generate hospital-specific fact sheets with their own NAS data that is compared to the state of Kentucky as a whole. They only receive their data. They do not receive identified data from other facilities. The information can be used from the hospital for quality improvement purposes, or if they want to enact their own prevention efforts within their community. Several key indicators that is included on the fact sheets include their own length of stay compared to the state as a whole, as well as what substances the infant was positive for and the mom was positive for compared to the state as a whole as well. Next slide, please. So some of the future initiatives that we are working on here in Kentucky, we annually link our NAS registry data with vital statistics. As I mentioned, that's the purpose of collecting the specific identifiers early on. And we compare those infants to the general birth population, and this is included in the annual report. We also link to Medicaid data. Early on, we had a study where we compared our NAS Medicaid infants to non-NAS Medicaid infants, and we discovered that the NAS Medicaid infants had a 3 times higher ER utilization than the non-NAS infants for non-emergency related purposes. And they were also less likely to have completed their routine well child health exams. The big project that we have coming up that we're very excited about is we are getting ready to work with our prescription drug monitoring program here in Kentucky it's called CASPR. We have a signed data use agreement and IRB in place, and we will be exchanging data with them to link moms from our NAS registry to the Casper system. And from that information, we are going to assess the moms who were on MAT versus the ones who were not and compare the outcomes of the two groups. And we plan to publish any relevant findings. We just had a meeting with the Casper people yesterday, and we are set to start the data exchange. So that is up and coming for Kentucky, and we hope to include some of that information as well in the annual report. Next slide, please. And that is all that we have from Kentucky, so I will turn it back over.
Thank you both. That was fantastic. I would highly encourage everyone to check out their annual report. Kentucky does a phenomenal job of putting all this information into very digestible pieces. And so it's an excellent resource for states. And for that data, the overlay of the NAS and the SUID data is just pretty phenomenal. They don't lie, right? So now we're going to move into a facilitated discussion. These are the questions that we prepared ahead of time to ask all 4 participants, Chelsea, Karen, Dr. Bada, and Tracy, for a facilitated panel discussion, if you will. It is intended to really get all the perspectives about this topic and the challenges associated with data sharing and the opportunities that arise as a result. So without further ado, I'm going to go ahead and read out the first question, and feel free to answer as you see fit. So your states, Kentucky and Pennsylvania, have both engaged in interagency collaboration in order to address NAS. Can you speak to how this collaboration began, what specific policy levers are used to facilitate it, and what platforms are used to maintain it?
I can answer briefly for Kentucky, and Tracy can add to it. We are very fortunate in Kentucky that several departments that we are engaging with are part of the cabinet for health and family services. So and we also have different divisions that we're collaborating with within the Department for Public Health. For example, we work with the Vital Statistics division, and they are actually part of the Department for Public Health. So it's really easy for us, or not easy, but this can facilitate collaboration. And of course, we have to have a memorandum of understanding or data use agreement with this, which is would have expiration. So we make sure that we can renew any memorandum of understanding or data use agreement. Tracy, you want to add to that?
I don't really have anything else to add. It's just, I will state that we have been very fortunate to have a very good working relationship with the other departments and divisions within our cabinet. And so that has really been the platform for leveraging all of this to begin with and maintaining and continuing it into the future.
And I can speak for Pennsylvania. I would say we're also fortunate in the state that our Bureau of Epidemiology and Bureau of Family Health are co-located in the same agency. As I mentioned in the presentation, we kind of had that transition of data collection between bureaus, and the fact that we're in the same agency and we're able to collaborate and kind of share responsibilities for NAS reporting is really an asset. And then in terms of outside of our agency, we have ongoing collaboration with our Department of Human Services, which has the Office of Children, Youth, and Families, as well as the Office of Child Development and Early Learning. So collaboration with that department is maintained similarly to Kentucky through data sharing agreements, memoranda of understanding. And in terms of maintaining those collaborations, I would say certainly, we do publish data in an annual report as well that's publicly available and that we share with our partners. And then also we've incorporated some of those collaborations into our Title V Maternal and Child Health Services block grant, into our action plan, so that we can, stay accountable and ensure that we're driving improvement, specifically in referral rates, things along those lines. That's really a focus of some of our collaboration. I don't know, Chelsea, if you want to add a little bit more about what that collaboration looks like.
Yeah, so I'm just going to expand on Karen's answer a little bit. So the Department of Health's Division of Newborn Screening and Genetics has 2 interagency collaborations to note this morning. The first is with the Office of Child Development and Early Learning, with a primary focus on early intervention. So the Division of Newborn Screening and Genetics provides the Office of Early Intervention with a monthly report containing NAS infants reported via ICMS. Early Intervention completes a cross-check and returns that report with updated information regarding EI status for each baby. So whether or not the baby was referred to early intervention, if they're active, inactive, or in at-risk tracking. And then that updated information is entered into ICMS and is utilized to extract aggregate data detailing the number of NAS cases with early intervention outcomes per facility and per county. And then that aggregate data is shared with early intervention on a quarterly basis. And the goal is to improve EI referrals for NAS infants. And then secondly, the Division of Newborn Screening and Genetics is in the process of developing a data share agreement with the Office of Children, Youth, and Families, which is housed within the Department of Human Services. And the purpose of this data share agreement is to improve upon the number of childline referrals and development of plans of safe care for infants diagnosed with NAS. However, I will mention this morning that this data share agreement is currently in process and hasn't been finalized at this time.
Thanks.
Great, thank you all. Sorry, I'm trying to look at all of the questions populating up while facilitating this. So I'm now wondering whether you can speak to what you have learned about the interrelationship among NAS, maternal or parental OUD, and maternal or parental mortality, and how you have leveraged that knowledge into policy change.
Again, for Kentucky, we are fortunate that we have the Maternal Mortality Review Committee, and actually this stemmed from the we have already a mandated Child Fatality Review Committee, which is interdisciplinary, and we thought, well, it would be good if we have. It's part of that is the mother, the outcomes of the mother. So it was merged into like a revision of the statute. And so both by legislation, we are to review both the child fatality and also the maternal mortality. And we just had our data, I think, from just starting about 2 years ago. And basically what we found, looking at maternal deaths within 1 year of delivery, that half of those deaths were actually related to drug use. And about 40%, I think has been, Tracy, correct me if, on this, I think about 40% is related to drug overdose and not necessarily to the medical complications arising from the use of drugs. So it's a constant review, and it's a way to actually give information to our other organizations like the Prenatal Quality Collaborative, and we have now become the AIM state to look at all these issues related to drug use and NAS. Tracy?
Yes, I don't have anything else to add. We're really starting to learn from our maternal mortality reviews. As Dr. Bada mentioned, we've only been doing those for a couple of years now. And with the majority of those deaths being among women who died from an overdose, I think that this will be a great partnership to really look into some of the community factors around that and what can be done to help prevent that.
Yeah, and I would say for Pennsylvania, the Department of Health is in the early stages of analyzing the data and the interrelationship between NAS, maternal opioid use disorder, and maternal mortality. The Bureau of Epi actually does have a CDC overdose data to action grant. So that's what's kind of facilitating linkage between NAS, our prescription drug monitoring program data set, similar to Kentucky, and additionally our vital statistics data, hospitalization data. So hopefully with all of those data sets kind of combined, we can see a more comprehensive picture of NAS, of maternal opioid use disorder, within the state and certainly among NAS cases. And I would say that our maternal mortality review committee can access and query our prescription drug monitoring program. So there are certainly kind of overlaps in areas where linkage is already happening, but it's still kind of early days. And we do intend to publish some of that information, once we're a little bit farther along. And other linkage, I think, with, for example, Medicaid data, as others have mentioned, which would be an informative link, is something that we're kind of hoping for in the future, but we're just not quite there yet in Pennsylvania.
Go ahead, Chelsea. Sorry.
Yeah, I was just going to add to that. I think we've also been able to leverage the knowledge gained through NAS surveillance to impact public health programming within our state. Through our NAS surveillance measures, the Northwest region of Pennsylvania has been identified as having the highest NAS rates within our state. And the Division of Newborn Screening and Genetics is currently working on a grant-funded project with a community partner in the Northwest region to initiate a pilot project for infants and families impacted by NAS. So this pilot project will consist of the development and distribution of an NAS toolkit in the form of a booklet and baby basket containing various items as identified by NICU staff as being fundamental in caring for infants diagnosed with NAS. So the pilot project is still in the early planning stages, but it's definitely something that we're really excited about.
Great, thank you all. Rather than continuing with this facilitated discussion, we are being overwhelmed with questions from participants, which I feel like we should get to instead. Just a quick shout out to Jordan from Pennsylvania, who is answering questions in real time. Thank you for doing that. All right, I'm going to try and toggle between the chat and the Q&A. So 2 related questions. Who is responsible for completing the data entry for each dyad, and who follows the baby to make sure everything is being reported after the birthing hospitals? I think for both teams.
Chelsea, do you want to take that one for Pennsylvania?
Yeah, so in Pennsylvania, it is the hospital's responsibility to enter the NAS case notification or to complete that in ICMS. With every case notification that's completed, we review it to make sure that it meets state reporting requirements and aligns with CSTE's case definition for NAS.
Okay, in Kentucky, the hospitals are also the ones responsible for making sure that data are submitted. However, we have, in the real world, personnel can change from 1 month to the other or 1 year to the other. So we have some difficulty tracking who is the person that's really responsible for reporting. However, we are now partnering with the Kentucky Prenatal Quality Initiative Collaborative, and we are having like a leader from each of the hospitals, trying to get a leader to make sure that they're able to report. The other thing that we are planning on doing is to make reports to the hospital, perhaps quarterly, to remind them that so many cases have been reported and this is what we anticipate you to be reporting in this quarter and then by the 6 months or by the end of the year.
Great, thank you. This is for Kentucky. I think I know the answer, but I'll let you answer. When do you anticipate having the 2020 annual report up? They are interested in seeing the changes over the past year.
We are currently cleaning the 2020 data as we speak, and we will begin analysis on that soon. We are required to have the report over to the legislatures by December 1. So it's a pretty turnaround time once the data is cleaned and analyzed and it runs through all of the approval levels and legal services. It will then go over to the legislatures and then it will be published on our website. So definitely by mid-December, it will be available online to the public. But usually it's over with the legislatures by December 1. And what was the second part of the question?
That was it.
Oh, okay.
They're just interested in looking at the data. So
Yes.
To both teams, I believe, are data available to community partners and or regional coalitions? If so, how do communities request data?
In Kentucky, we have, like I mentioned, it's published on our website, but we also have a general NAS email address that comes to Dr. Bada and myself and another EPI member who works on NAS. And so we filter and funnel those questions and respond in real time. And so anyone can send in a question or comment to that NAS web address.
Yeah, and in Pennsylvania, as our 2018 and 2019 surveillance data are also published in annual reports that are available on our website. And then I think otherwise, if we were to receive data requests, we would handle those on a case-by-case basis from community partners or stakeholders. But it's some of which is already, again, as I said, available through the reports.
Great, thank you. To address the epidemic, we hope to increase access to MAT for pregnant women with OUD. This may result in increases in diagnosed NAS. Do your analyses address this distinction?
We are trying, we just have this MOU with Casper, with the OIG, and that's one thing that we're interested in looking at. To look at the prevalence or the percentage of babies with symptomatic NAS, the percentage of babies born to mothers who are on MAT, and the mothers who are not on MAT, and we'll make that comparison. But I'm interested in finding out what we're going to find out, but at this point, we still are at the process of data exchange.
And in Pennsylvania, part of that case report form, there is a section where the reporter is asked to indicate whether the birthing person was on MAT. So that's something that we will be able to address more specifically moving forward, since with the new case report form that Chelsea walked through today.
Great, thank you. And I think there's a similar question about the difference or distinguishing between prescribed versus illicit substance reporting. And I think you both just spoke to that to an extent. So is the Kentucky NAS Surveillance Registry working alongside their birth defects registry to provide additional resources for children who develop long-term health conditions?
The birth defect registry is under under the Maternal Child Health Division, but we are still at the point wherein we have not looked into linking the data set from the genetics, newborn screening, or birth defects and NAS. So it's something that we would be looking at.
Great, thank you. Are either states comparing reportable NAS to DOH with child welfare data on the number of infants and parents with a plan of safe care?
Can you repeat the question? I mean,
Absolutely. So is either state comparing reportable NAS to, I believe, Department of Health with child welfare data on the number of infants and parents with a plan of safe care?
We are working with the Department of Community-Based Services, and we are all, both departments are focusing on the plan of safe care. I think there's a connection between DCBS and us, because what's happening is most of our hospitals are reporting to DCBS when they have a baby with a diagnosis of neonatal abstinence syndrome. And but of course, we understand that not all of them are going to be not all of the cases will be investigated. So we rely heavily, as plan of safe care, we rely heavily on the findings of DCBS. And we have come to a point where, like, as a practitioner, we really await the DCBS findings before we even discharge the infant. But in addition to that, we have public health is fairly active in promoting parenting education, improving parenting skills of mothers who are on MAT, and if we find out that they have been using drugs during pregnancy.
Eliza, I can speak for Pennsylvania. So plans of safe care, this is definitely something that is on our NAS report form. So the hospitals will check off whether or not a plan of safe care was initiated. However, we would definitely like to do more of a deep dive and compare data with the Department of Human Services to kind of fine tune that data. However, I think one of our biggest and most challenging hurdles has been the inability to share data in certain circumstances between state agencies because of the type of information that you're dealing with. Unfortunately, I don't know that we could implement a policy change immediately to tackle this issue without I think the magic wand question was in there. So without having an actual magic wand. However, even though we may not have the ability to share all of the information that we'd like to, I think we can certainly consider what can be shared in order to implement change and positive outcomes for the infants and families. So in other words, I think we can think about how we can share our data, remain flexible, send or receive aggregate data instead of maybe the complete data set, which would certainly be the ideal situation.
Thank you. We have another question that just came in. Is comparison data from other states available for the percent or rate of children with NAS on Medicaid or CHIP specifically? And I guess maybe do you all reference comparison data? I think it's part of that question.
I think one of the challenges, and I'll be curious to hear what Kentucky says as well, is that different states have such different case definitions and reporting systems that, that interstate comparison can be a challenge, depending on the method of surveillance. But I know that there is some like hospitalization-based data available at the national level. And I believe that's also, based on, again, hospitalizations available for each state. But in terms of comparing surveillance data, like the data we talked about and collect, that can be a little bit more challenging. But turn it to Kentucky if you have any other insight.
We have not specifically compared the Medicaid analysis within Kentucky to other state Medicaid NAS analysis. We just specifically looked at what was going on in Kentucky and shared that with our Medicaid medical director and other folks over in Medicaid. As you mentioned, it is very difficult without all 50 states, so to speak, having the same case definition or even collecting the data to start with, do a real national comparison, but we hope to be moving in that direction in the future.
Great. Thank you all. This was phenomenal. There's been fantastic discussion happening in the chat that I've been kind of tracking as I go. We are almost at the top of the hour, and so I want to respect all of your time. Several people asked about the presentation. The slides, the recording will all be posted on our website. The slides do have email addresses for all of our speakers here today. Thank you to our speakers. You were phenomenal. The presentations were fantastic. Please fill out the evaluation at the end. Thank you to Karen Scott for being on here today, and I hope you all enjoy the rest of your days. Take care.